Good afternoon, everybody. Welcome on a fine May Day morning, lunchtime. Welcome to our ExChange seminar series featuring equalities, diversity, inclusion in children's social care. So I can see about 10 people, 13 people in the room, and it's 4 minutes past. So I'll start the seminar, and hopefully we'll have more colleagues joining us. And a very warm welcome to our first in this series, a webinar today featuring Dr. Yongchao Jing, research associate to many of you in Cascade won't be a stranger, and a research associate for over 2 years now. And Yongchao is working on a research project on called ERICA in short, ethnic and religious disparities in the healthcare utilisation of children receiving care and support in Wales. This particular paper is part of a wider project funded by the HCRW Research Health and Care Research Wales. And the wider project is on ethnic and religious inequalities in children welfare, exploring outcomes in education and also health utilisation patterns. And Yongchao has already published with the ERICA team on ethnic disproportionality in the children welfare in the British Journal of Social Work, and another paper on educational outcome is under review. And very warm welcome to everybody joining us. And so the seminar will proceed as the follow. Yongchao will give us a presentation, approximately 35-40 minutes, and then we'll open the Q&A. So if you have questions, you can post it on Q&A, please, so we can gather all the questions in the order they come in. Or if you wish to raise your hand later on as the discussion unfolds, you can do so as well. We have colleagues in the room who can unmute you. So without further ado, over to Dr. Jing.
Thank you very much, Cindy, for the kind introduction. And many thanks everybody for being here today. And I will be presenting on behalf of our research team, and Cindy is PI on this project, who is also with us here today. As Cindy just introduced, this research project has now come to nearly the end, so that we have a paper already published at BJSW and another one focusing on the educational attainment that we have a preprint available on SOC Archive. And today I will be presenting our newest findings on ethnic and religious disparities on health service usage among children receiving care and support. So to give a brief background, and I suppose this isn't new to most of the audience. So the population that we are focusing on in this research is children receiving care and support, which is a group of vulnerable children who receive care and support from social services. So they have a variety of needs, including protection from abuse and neglect and disability. Within this group, a subset of children are placed on a child protection plan or looked after by local authorities. But despite this heterogeneity within CRCS, because of our focus on the ethnic and the religious minority groups, so we can't really have further disaggregation into the more refined groups within CRCS. So in this research, we will be focusing on the whole group of CRCS, despite the heterogeneity that we just talked about. And in this research, we will be focusing on the healthcare utilization patterns of ethnic minority groups, and we distinguish between 4 groups, that is Asian, Black, mixed heritage children, and other ethnicity children. And for each of these groups, we have 2 benchmark comparison groups to compare against. First is that their white counterparts also in CRCS. that is comparison group 1 shown here. And then comparison group 2 is children of the same ethnicity, but who are not CRCS children. And similarly for religious minority groups, that we distinguish between Muslim, other ethnicity, and non-other religion and non-religion. And then we compare to the Christian CRCS children, and we also compare them to children with the same religious identity but who are not CRCS. So to give a bit of background, we have learned from previous studies that children looked after have poorer mental and physical health. And also the more recent research that uses the administrative data also show that children receiving different levels of social services also have heightened use of certain types of healthcare. And this is found in all 4 developed nations of the UK. So our research builds on this line of inquiry and further to explore the ethnic and religious differences. Because we know that Black and mixed heritage children are involved with the UK child welfare system at disproportionately higher rates than their white counterparts. So these children not only have higher levels of mental and physical health needs, but they are also likely to experience ethnic disparities in many areas of health services access or utilization. So all of these evidence points to the potential ethnic disparities in healthcare utilization within children in contact with social care services. But despite this, we still have little empirical base in the UK. So our research is hoping to fill in this gap. So our research will investigate the patterns of ethnic and religious differences in healthcare utilization among children receiving care and support. And we do this by using linked administrative data in Wales. So first, we will explore the ethnic disparities in the pattern of healthcare utilization of CRCS children. And then we are also the first to be able to identify the religious identities of CRCS children and report the religious differences in healthcare utilization patterns. And then we will report both the utilization patterns of 3 categories of healthcare use: GP visits, that is general practitioner visits, hospitalization or inpatient hospital visits, and A&D visits. And for 3 reasons of visit as well. So first is for all reasons, second is for mental health conditions, and third is for injuries. So we have this 3-by-3 table to show our 9 outcomes of interest, so that for each type of healthcare service, that is GP, hospital, and A&D, crossed with the reason for visit, that is for all reasons, for mental health conditions, and for injuries. So in total, we have 9 unique combinations of each type of healthcare service and the reason for visit. We accessed our data from SAIL data bank, which is Secure Anonymized Information Linkage data bank. So the SAIL data bank contains extensive anonymized health, social care, and education data about the population of Wales, and they are accessible in anonymized form via a trusted research environment, all underpinned by an innovative and proportionate information governance model. All data within SAIL are treated in accordance with the Data Protection Act 2018 and are compliant with the General Data Protection Regulation. So all the personal identifiable data were not used in this study. So the way we built our data is that we first built a 1-year cross-sectional data for all school-aged children aged 5 to 16 in children receiving care and support, or CRCS, for each year of year 2017, 18, and 19, which are all the years that are not affected by COVID-19 and which cannot be directly comparable with previous years due to the change of legal framework. So for each year, CRCS includes cases that have been open continuously for the 3 months from 1st of January to 31st of March in the return year. And for each year of 2017, 2018, and 2019, we built a randomly matched non-CRCS comparison group from Welsh Demographic Service dataset by 1-to-4 matching based on gender, age, and Welsh Index of Multiple Deprivation, or WIMD. So combining CRCS and the matched non-CRCS group, we have our analytical sample. So our research adopts a repeated cross-sectional design because we are combining 3 years of data together. This is a suitable approach for study of subpopulation where sample sizes are small in individual cross-sectional data sets, like our focus here is on ethnic minority, which is a very small group to research on. And we applied 2 restriction criteria to the data. First, to be included in our analysis, children need to have an anonymized linking field, or ELF, which will enable the linkage to individual level healthcare data. So this is to make sure that we don't mistakenly view children whose ELF are not identifiable as not utilizing healthcare services. Further, children who need to be registered to a self-providing general practitioner for the full year to be included in our analysis. And this is also to avoid that we mistakenly view children who moved out of Wales as not utilizing healthcare services. And the data linkage part, we linked GP hospitalization and A&E records to our analytical sample, which includes both CRCS children and their matched cohort. So to improve data completeness for the ethnicity variable, we further linked to Census 2021 and 2011 to identify their ethnicity from these 2 censuses if they are missing in the CRCS data, so that we could reduce the missingness of ethnicity in the CRCS by around 50%. And we were also linking to the 2 censuses to identify the children's religion. So again, this table shows the 9 outcomes of our research, and each outcome is measured as whether the person had at least 1 visit in the year, so that these outcome variables are all binary variables, that is yes or no. Ethnicity is measured by 5 broad categories: Asian, Black, mixed heritage, other ethnicity, and white children. And religion is measured by 4 broad categories: Christian, Muslim, other religion, and no religion. So to estimate the differences in healthcare utilization between CRCS and non-CRCS children by ethnicity, we conducted a logistic regression model of healthcare utilization, which are binary variables on CRCS status and ethnicity, as well as their interaction terms. So we report the estimated probabilities of having at least 1 healthcare visit and also confidence intervals for each combination of ethnicity groups and CRCS statuses. Since we are using population level data rather than sample surveys, tests of statistical significance are not appropriate. So instead, we are focusing on the interpreting the practical insignificance instead of statistical significance of these group differences. So to give some descriptive statistics of our analytical sample, so the left-hand table shows the distribution of ethnicity, including missing as a category here. So around 1.46% of children, we can't identify their ethnicity even after data linkage. And we can see a majority, that is around 83% of children are white. And then ethnic minorities varies between around 1% for Black children to around 6% for other ethnicity children. And the proportion of missing is considerably higher for religion because we can only identify these children's religion from census data, and they are not available in the CRCS data like ethnicity does. So that the missing is around 17% for religion variable. And we can see that the majority actually is the non-religious group, which is around 50%. And then is Christian around 27%. For Muslim, it's around 3%. And other ethnicity is quite low, around 1%. So because these graphs that I'm going to present have like abundant information, so we will mainly make three ways of interpreting these findings. So we will first focus on two comparisons within each graph. So first, within each graph, we compare the probability of healthcare utilization between CRCS and non-CRCS children to see if the pattern is consistent across ethnicity and religion. And the second, among CRCS children, we will compare the ethnic and religious differences in healthcare utilization. And then finally, we will try to summarize some common ethnic and religious patterns across different healthcare utilization outcomes. So for example, for GP visit, for the three reasons of visit, whether there are some general patterns seen for ethnicity and religion. So here I realize these graphs are a bit small to see, but in order to show them all in one screen to allow some comparison, I will introduce that the first row are shown for GP visits, and the second row is for hospital visits, and the third row is for A&D visits. So the first column is visit for all reasons. Second column is visit for mental health conditions visit. And third column is for visit for injury reasons. And the red line represents for CRCS children, and blue line represents for non-CRCS children. And please do notice that the scale for the y-axis are different by graph. So this is because the level of prevalence for different visits are quite different, so that if we use the same scale, then some of the patterns of lower prevalence may not be clearly shown. So that please pay attention that the scales are different when we are comparing the absolute level across the different graphs. So to start with the first graph, for GP visit for all reasons, we can see the probability of visits are higher for non-CRCS children than for CRCS children. And for mental health conditions, the pattern is reversed. So CRCS children have a much higher probability of visit. And for GP visit for injury reasons, the level are kind of similar for CRCS and non-CRCS children, except for other ethnicity children. And among CRCS children, we can see that white children tend to have the highest probability of visiting for all reasons for mental health conditions and for for injury reasons, whereas Black children tend to have the lowest probability of visit across these three reasons of visit. And then moving on to the hospitalization, that is the second row, we can see that CRCS children consistently have higher probability of visiting. And this difference is especially big in the middle picture, which is for hospitalization for mental health conditions. So CRCS children have around 3 to 5 times the probability of non-CRCS children for hospitalization for mental health conditions. And then among CRCS children, we see that mixed heritage children to have rather a lower level of visit, whereas Asian children tend to have the highest probability of visit for the three reasons. And then moving on to A&D visits, we can see that the pattern for all reasons and for injury reasons are kind of similar, so that CRCS children and non-CRCS children have similar probabilities of visit. But again, for mental health conditions, CRCS children have much higher probabilities of visit. And then moving on to religious differences. So these graphs are presented in the same order as we did for ethnicity. So that first row is for GP, middle row for hospitalization, third row for A&D visit. And the columns respectively are first column for all visit for all reasons. Second column is visit for mental health conditions. And the third column is for injury reasons. So that we can see again, for all reasons, non-CRCS children have higher probabilities of visit than CRCS children. But for mental health conditions, CRCS children have higher probabilities of GP visit. And for GP visit for injuries, the probabilities are rather similar between CRCS and non-CRCS children. And then moving on to hospitalization for all reasons for mental health conditions and for injuries, we find the probability of visit to be higher for CRCS children than for non-CRCS children. And the biggest gap is again among the visit for mental health conditions. So the CRCS children have around 5 times the probability of that of non-CRCS children. And we can see here a rather consistent pattern is that Muslim and other religion children tend to have higher probabilities of hospitalization compared to Christian and non-religion children group. And then moving on to A&D visits, the patterns are rather similar for CRCS and non-CRCS children, for all reasons visit, and then for injuries visit. But for mental health conditions, CRCS children still have higher probabilities of visit. So to quickly summarize the findings, if we ask, do CRCS children have higher healthcare utilization for all ethnic and religious groups, then the answer can be partly yes. So for hospitalization, for all reasons, for mental health conditions and for injuries, And for mental health conditions at 3 types, that is for GP, hospital, and A&D visits, CRCS children do exhibit higher probabilities of at least one visit compared to non-CRCS children. And we find the starkest difference to be for mental health conditions. And the answer is no if we look at GP and A&E visits for all reasons and for injuries, because CRCS children have lower or similar levels of healthcare utilization for most ethnic and religious groups for these measures. And second, if we ask, do ethnic or religious disparities in healthcare utilization among CSS children reflect that in the general population? Our answer would be no. The patterns of ethnic and religious disparities among CSS children are largely distinct from those observed in non-CSS children. So to give an example, well, we see that white children appear to have the highest probability of at least one hospital visits, like for all these 3 types of reasons among non-CSS children. Asian children actually have the highest probability of at least one hospital visits among CSS children. So another example is that the probability of at least one hospital visit is similar across religious group among non-CSS children, but we see that Muslim and other religion children to have higher probabilities of visit compared to Christian and no-religion children among CSS children. And finally, among CSS children, so what are the more consistent patterns of healthcare utilization for different ethnic groups? So we briefly summarize here that for Asian children, they are among the highest probabilities of at least one hospital visits. So for all these 3 types of reasons. And for Black children, we see they have the lowest probability of having at least one visit for GP visits. For mixed heritage children, they have the lowest probabilities of visit for hospitalization. And other ethnicity children are among the highest probabilities of at least one visit for A&D visits for these 3 types of reasons. And for white children, we see that they are among the highest probabilities of having at least one visit for GP visits. So for religious differences, we see that Christian and no-religion children among CRCS, they have higher probability of GP visits, but lower probability of hospitalization. However, for Muslim children, they have the lowest probability of GP visit, but the highest probability of hospitalization and A&E visit for mental health conditions. And if we look at visits for all reasons, other ethnicity children, they have the lowest probability of visit at GP level, but they have higher probability of visit at hospitalization and A&E levels. So what can we tell from these findings? Because we see that Asian children, they have high probability of hospital visits, this may suggest potential gaps in earlier intervention or primary care access, while the low GP attendance among Black children may raise concerns about systematic barriers or mistrust that hinder routine care. In contrast, white children's higher GP attendance could indicate more effective engagement with primary care services. And mixed heritage children's low hospitalization rates warrant still closer examination to ensure that needs are not going unmet. The high A&E use among children of other ethnic backgrounds may reflect inadequate access to urgent care alternatives or limited familiarity with healthcare pathways. So these patterns together underscore the need for targeted and culturally competent strategies to improve access, strengthen early support, and reduce inappropriate reliance on emergency or acute services across different ethnic groups. And then for religious disparities, we see that children from Christian and non-religious backgrounds are more likely to access GP services and less likely to require hospitalization, suggesting earlier or more effective engagement with primary care. But in contrast, Muslim children are less likely to access GP care, but more likely to require hospitalization or A&E visits for mental health conditions. So this can indicate potential delays in treatment or unaddressed needs. Similarly, children from other religious backgrounds, they show lower GP engagement but higher use of acute services for all reasons, raising concerns about access barriers, cultural stigma, or lack of tailored services. So these patterns together suggest a need for culturally and religiously sensitive outreach, improved mental health provisions for minority faith communities, and targeted efforts to ensure earlier and more appropriate healthcare engagement across diverse religious groups. So I'm presenting on behalf of our team, including Lucy and Grace based at Swansea University, and Jonathan and Singi based at Cardiff University. And we would like to thank our partners of Cell Data Bank, as well as the EAST group, which we had support from our engagement team members, Rachel and Elaine, to help us hold several service users panels that informed our research. Yeah, thank you very much, everybody, for your attention.
Perfect timing, Yongchao. That was very, even we actually talked about the slides and then talked about the findings as we produced them. And we actually, I still find them interesting. I am biased, of course, part of the team. And the floor is now open for, we have more time for Q&As. Do post your questions on Q&A. And I think maybe there are already some questions popped up on in the chat, so I will read them out in the order they came in, and let's just see. I think I picked up the first one. If you do wish to ask the question yourself, feel free to raise your hand, and colleagues will unmute you. So first question from MC Hunter. How comprehensive are the cell data sets to enable you to answer your research questions? I imagine there may be a number of difficulties in ensuring that you have complete sets of data for individuals, especially from this vulnerable group. The fact that data is anonymized is essential, obviously, but it means that you wouldn't be able to investigate any missing data either. We do have a team member, data linkage expert, Dr. Grace Bailey, in this call. So I will be relying on Grace, if that's okay, to answer questions that I don't have a good enough answer to. So I have to go in answering this, and Yongchao can chip in. We do have complete population data and the social care data. So as long as they are on the social care data register and children receiving care and support, we do have access to every single one of them. However, data linkage means that we have to have this individual identifier, what Yongchao referred to as ALF, the ELF, the anonymized flag. So where the educational health data do not have that flag, we can't link them. So there will be incomplete coverage. So you're absolutely right. And I called in terms of data, knowing who these people are, we can't tell analyze the missing data. That is to some extent true, but we do have the other side of the data. If they are linkable and they're not giving the key variable that we want to know, like ethnicity and religion, we do know sometimes that by the information from other data set, some characteristics, but the project, we don't have time to do a lot of missing data analysis. On top of that, our first paper published in the British Social Work, Journal of Social Work, we demonstrated that by linking the social care data to census 2011, we managed to improve the data missingness on the ethnicity flag by over 50%. So that is in itself a clear methodological contribution for this project alone. And in terms of the religion, it's the very first time we are aware of anyone doing this kind of work at all, because we were linking the Census 2021 religion identity data to social care data set. I can talk more about that, but I can see questions are coming in. Yongchao, do you have anything to add, or have I said anything incorrectly?
I think that's very comprehensive. Thank you, Xing.
Grace, if you have anything to add, please do unmute yourself and chip in. Second question, also from MC Hunter. If the children live with foster carers and kin carers, do you have any data on the ethnicity or religion on the carers too? No, I don't think we have the ethnicity or religion or any social class data from the carer. Please do correct me if I'm wrong, team.
You're right, Xing. We don't have, yeah.
We only have the children on the social care data set, these characteristics, but not the carer. That would be a very interesting avenue to pursue, obviously, in future, if we can link it to any other data set that we can establish that will make a big headway in some of the analysis we are able to conduct. Other questions? Are you able to see also from MC Hunter? Anyone else got any questions? We will get through this one first. We've got a bit more time today. We're lucky. Are you able to see the geographical location in which children reside in and analyze the level of GP services provided in the area? It may be more of a socioeconomic deprivation concern as opposed to a specific link to ethnicity and religion. Good question. We do have in the model we ran. Yongchao, why don't you answer this? You're an expert on this. We use the IMD.
Yes, thank you, Xing. Yes, yeah, you are quite right that the level of like deprivation or socioeconomic background can play a very important role. Yeah, so that's why when we were building our comparison group of non-CSS children, we matched on WIMD, which is area level measure of social economic background, which is not ideal as individual level measures of social economic background, but that is basically as good as we can get when drawing upon administrative data. Yeah, so yeah, very valid question, but yeah, we matched on WIMD, but not, a perfect measure for socioeconomic background. Yeah.
I can see a question from Asma. Thank you for attending. And just a note to that is WIMD is the index for multiple deprivation, is an area-based deprivation statistics. So to a degree, it already take into account of the area. It may be that they are definitely living in a socioeconomically deprived area if they are in the lowest quintile. So we don't know the actual socioeconomic background of the family, but we know the area the children live in by divided by 5 quintiles. So the lowest 20% as opposed to the highest 20%. So that's already in the model. So what we're observing, these ethnic or religious differences is net of, i.e., in addition to those socioeconomic deprived neighborhood they're living in. So it is effective, assuming that they see the GP also in the local area. So that is in effect accounted role in the model. Question from Asma, moving along. Can you tell us whether ethnic or religious differences were more pronounced, particularly interested in regarding mental health? So we can compare, they are directly comparable, the magnitude of the difference between CRCS and non-CRCS. So is it the middle chart? Can we go back to the
Yes.
the two findings slides to have a look at the gap? So we're looking at right in the middle of the grid of hospitalization and mental health. So the middle column is mental health, isn't it, Yongchao?
Yeah, that's right.
So this is the gap.
Yeah, and this is for ethnicity differences. So for example, for GP level visit, it's like around 2 times. So CRCS students have around 2 times the probability of that of non-CRCS student. And then at hospitalization level, it's between 3 to 5 times according to ethnicity. And then here for A&D visit, it's around, sorry, this line of non-CSS student is quite low. So I need to check the numbers to see how big this gap is. But then if we compare with the religious differences, so for example, at GP level, it is still like around 2 to 3 times, I would say, the gap. And then for hospitalization level, it's around 5 times that of non-CSS children. So from face value, it seems to be that religious gaps are relatively more significant, if I may say, for these two measures, that is at GP and hospitalization levels. But for A&D visits, again, I will need to check, this very low number, but it seems that, yeah, but the scales are kind of different, so I can't really compare directly. But yeah, I'll double check, and very good question if ethnic disparities are more distinct or religious differences.
Thank you, Yongchao. I can't read the scale of the chart, so that your explanation of the magnitude, whether it's 2 times or 3 times, is essential. Question from Louise Roberts. Fantastic, comprehensive presentation, and loved it. Thank you very much for the praise. Yongchao is really good. What informed your choices to focus on the 3x3 categories? Was it previous research, engagement work, or data availability? Were there any particular key areas you would have liked to further explore, for example, outpatient or other types of presentation of Louise doesn't have speakers today, so she can't ask the question. So I know the answer, but I let Yongchao answer it.
Yes, very good question. So yeah, I would say both. So from previous research, they were focusing on similar outcomes, and also because these are available outcomes that we can access in CL Data Bank. So the first is like visits for all reasons, which is a more comprehensive measure of healthcare utilization. And then we chose to focus on the two specific conditions, that is mental health conditions and injuries, because previous research shows them to be rather prevalent among children receiving care and support. And also there is previous literature suggesting that early career adversities, like the ones that CRCS children may face in their early life, can directly lead to like mental health conditions, problems, etc. So that these two outcomes are quite relevant for the population that we are interested in. And that's why we, in addition to the visit for all reasons, we zoomed further into for mental health conditions and then for injuries as well.
Great, thank you. Absolutely, because numbers are key here, because we have to work with two very, very small groups, children in social care and religious and ethnic minorities. That explains why there isn't abundant research and evidence base out there. We're the first one to take on some of this work. But there is parallel work in Scotland and in Northern Ireland going on, but certainly for religion, this is the first time we are able to unveil the patterns behind these health utilization patterns. I missed a question from Madeline. I do apologize. Do you think culture and religious beliefs play a part in the disparity? Yongchao, would you?
Yeah, thank you. Yeah, very good question again. Yes, my answer, I think my answer is yes, because we do see quite distinct religious and ethnic disparities in the patterns. And then, as we discussed before, we also considered for socioeconomic backgrounds, right? So it is likely that these patterns that we see are attributable to cultural and religious backgrounds. However, that said, we don't have data to make causal inferences about why these children are, for example, choosing lower level of GP visits but higher level of hospital visits. So what we can do is like infer some possible explanations, but we can't really tell for sure if that's cultural reasons behind them instead of, for example, individual level socioeconomic backgrounds are behind this, right? Because we don't have very good measures for socioeconomic background at individual level. See, do you agree?
Yes, absolutely. On that note, we debated in the team. Grace, by all means, chip in if you wish. We talked extensively about different cultural perception and cultural and needs we don't know anything about between groups, and certainly these children, Yongchao, correct me if I'm wrong, we focus on school age children.
Yes.
So they start from age 5, so that already exclude a whole lot of vaccinations visits to GP, right? Because there are different cultural perceptions to vaccination, and we had all these MMRs vaccination scare a few years ago. So people have different takes on health services usage, and certainly even more recently COVID, not everybody believed that vaccination is the answer. So there is certainly cultural differences and religious differences in health services usage, and that might be in part explain the disparity in the patterns we observe. So Yongchao already helpfully outlined some of the educated guesses, so we're guessing these might be what's going on because the data are not strong enough for us to directly test the hypotheses. So we can only make a number of conjectures at this point, but we are making a start. Okay, questions still coming in. I'm conscious of time. I'm just getting to the next one. Do you have any data on ESL status? Do we have any English as a second language? Am I right? We don't. Is the answer. Yeah. Yongchao is shaking her head. Do come back if you want to follow up on the questions. I'll deal with the next one in the interest of time. Could it be specifically with mental health families may try alternative treatments like religious healings, but access hospital services when they reach crisis level? Your guess is as good as ours. It is possible. Grace is typing. Thank you. Language information is available in the dataset for the project that we did not have it. Yeah, for this project, we didn't have it. So if we have more money from the funders, we could extend and request that variable. So we spend all our money now. So we're coming to the end of the project at the end of June. So we're wrapping up. So this is our final analysis on health utilization, health services utilization pattern.
Yeah.
And
sorry. And thank you, Magdalene. I think that's a very useful explanation, right, for why GP visits level can be low. So it is possible that these families are not seeking for GP help at that level of crisis, as you say, or it is possible that even though they want to access that, but because of certain barriers or limitation in access, that they can't. So we can't really know if it's basically supply side explanations or demand side. But yeah, that's a very plausible reason to interpret the findings. Thanks.
And Madeline also put an honor, yeah. So it's certainly, but they are all very plausible explanations. We got 2 minutes. Can have a couple of more questions or comments and thoughts.
Yeah, I want to say thank you everybody for all the excellent questions. Very helpful discussion. Thanks.
So yes, if they're a really excellent discussion, thank you for all your input, and they are very insightful and thoughtful comments. If there are no further questions, we just please answer our poll. And for the next session, our exchange events are upcoming on the theme of equalities, diversity, inclusion in children's social care, including a film screening in Spark on the 5th of June, but that is in person only. And on the 16th of June, we have adoption lecture, and that will be hybrid and held in the Glamorgan building and on Teams. So watch this space and join us next time, and looking forward to seeing you all.
Thank you, everybody, for attending today.